I'll go to my topic proper. So now the topic given to me is to analyze an article called as "Amazing Trial." Now this was published in the
Dr. Niranjan, make it slideshow, please. That will be bigger.
my slides are moving.
Slideshow.
Oh, just give me 1 second. Sorry. Is it okay now?
No, go
No.
to the slideshow.
Okay. Share.
Yeah.
Oh, sorry. I thought it's already there. No?
Yeah, now it is.
Oh, sorry. So now the topic given to me is to analyze a trial, the role of prophylactic hydration in contrast-induced nephropathy prevention. So as we are already running late of time, I'll try to do justice to my talk now. So we'll start directly from the background or the pathogenesis or why at all fluid and why in contrast-induced nephropathy. So where from this thought came to hydrate a patient whom we are going to give contrast. IV fluid is like it's not antidote for the contrast, but still the thought is revolving. Now this thought came way back in 1981. So when a group of radiologists, when they felt or when they observed that the contrast-induced nephropathy, the incidence is low in the summer, and they published the paper in American Journal of Radiology. Now, after that was the beginning, they thought probably it is because in the summer, because the volume status, the hydration or the dehydration is more. So that is the idea. From there it evolved. There are so many like small trials came, some in favor, some against. Now the recent trials, if we talk about, all revolves around maybe 2010 to 2015. Now the trial, what I am talking, start from 2014 to 2016 again. So this is one among a few other trials which try to answer again why at all IV fluid, and actually does actually IV fluids protects the kidney from the contrast-induced nephropathy or not. So now IV fluid is recommended in various clinical practice guidelines, even if it is not proven in a big RCTs with a robust evidence. Still, near about all the international guidelines, they do recommend to hydrate a patient. Some guidelines, even they've given the dose, the timing, the 12 hour before, during the procedure, after procedures, but they, by and large, they are not supported with a robust evidence that hydration actually do protect the incidence of the CIN. Now coming to this trial, so this is basically, it's a 1:1 prospective randomized trial. It's a parallel group. Now the intention was to check the non-inferiority of not giving hydration or the non-hydrated group compared to the hydrated group. Now they put the like primary outcome as the development of contrast-induced nephropathy. Now the definitions they quotes from the rifle criteria, because during that time the rifle was prevalent there. So they mentions if within 3 to 6 days, if the creatinine clearance decreases by 25%, so then they categorize those patients as the CIN or contrast-induced nephropathy. Let's see how the trial they have conducted the trial. Now, from 2014 June to 2016 July, near about 660 patients they have enrolled. Then they were divided like 307 patients, near about 92%, and to hydrated, and 328 patients to not hydrated group, and they try to analyze the results. So now their inclusion criteria was patients were eligible to be included. First criteria was the estimated GFR should be below 60. Now they further categorized them from 60 to 45 and 45 to 30. They excluded patients with eGFR less than 30. Now, out of those patients, they further subcategorized like patients with eGFR 45 to 60. at least either they may be diabetic or at least two predicted risk factors like having anemia, having cardiovascular disease, or patients on NSAID non-steroidal anti-inflammatory drug, or maybe on diuretic or any nephrotoxic medications. Second group or the second strata is GFR between 45 to 30, or patients specifically with multiple myeloma, lymphoblastic lymphoma, and small chain proteinuria. So these are the subgroups they made. Now, in the exclusion criteria, so they kept patients who already had patients on renal replacement therapy, eGFR less than 30, patient in ICU. So this is especially for stable patients. Inability to obtain the informed consent, of course. So these were the exclusion criteria. Now let's go to the randomization. So it's a computer-based randomization, 1:1. As for the group into hydration, H plus or non-hydration, that means the H minus, the named in that way. Now, the randomization was stratified further by the volume of the contrast received, the volume of hydration they had given, and the comorbidities and the severity of the patients they received. So this is the study methodology. Out of 28,803 patients in that hospital who got the IV contrast, out of them they selected 660 patients, so whom they categorized to 328 patients to hydration group and 332 to the non-hydrated group. Now the exclusion to 26,970 patients where the eGFR was more than 60, they ruled out. Then few other patients even from 328. There were 68 patients whose creatinine value was not available before they came. So like this, they ruled out in the hydration group. 72 patients from the non-hydration group, but at the end of the analysis, they included all, as the study was intention to treat analysis. Now, demography wise, there was no great difference between the hydration or the non-hydration group in terms of age or the comorbidities. So you can see the H plus or non-H plus group near about same. The p value was not more than not less than 0.05. So they have mentioned both the groups, the mean age was 71, 72. So this was the group they tried to analyze. Let's see the outcome, what they found. They saw the outcome in terms of one is primary outcome, second is the secondary outcome. Primary outcome was simple. The incidence of CIN or the contrast induced nephropathy developed between 3 to 6 days or 2 to 6 days after the contrast. The secondary endpoints were like the adverse effects patients they developed. One more primary outcome they analyze is the cost effectiveness of the hydration versus non-hydration group. So that was their the target. So let's start with the primary outcome of the incidence of CIN or the contrast induced nephropathy. So they categorized to diabetic group, patient with eGFR less than 45, or interventional type of interventional procedure. Now you can see here, so there was no difference between the hydration versus non-hydration group in neither subgroup, in none of the subgroup. Maybe it's the diabetic, maybe the patient with the decreased eGFR, or patients with interventional procedures. So the confidence interval, you can see minus 2.8 to 4, minus 3.2 to 2. So confidence interval crossing 0, that means the result sometimes in favor, sometimes they are going against the trial. That means sometimes they favor the hydration, sometimes they do not favor the hydration group. This is the cost effect analysis. Now this is one they have extrapolated from a simulation, but this is very interesting table they have plotted here. You can see here, so the y-axis is showing the cost axis, x-axis is showing the effect axis. Now in the x-axis, the 0 mark shows the effect is 0, From right side to the effect, that means there was positive effect. Left side to the effect, that means there was less effect or the less outcome. On the y-axis, so 0 shows there is no additional cost. Towards upper direction, that means there was further additional cost, and towards lower side, that means the cost was lesser. Now, you see here, they have plotted here the hydration group. Now, in hydration group, the right lower bottom shows no hydration is more effective and less costly. So, near about 45% of the patients, they found it was more effective and less costly. So they've created similar plot for the non-hydration group as well. Hydration group as well. The left lower the box shows the non-hydration group to be again less costly but less effective. Now, when they analyzed or when they compared this effect, the cost effectiveness of the hydration and non-hydration group, they found a statistically significant difference of cost effectiveness of non-hydration group, and they further came with the reports the less or the cost effectiveness of the non-hydration group is because of keeping the patient in drier site by making them not to go to heart failure, less of pulmonary edema, less of ICU stay, less ventilator day, and less of less the cost. Now coming to the other side, the secondary outcomes like the major side effects, they didn't find a significant difference in terms of the development of acute kidney injury, development of or the dialysis dependent among the hydrated and non-hydrated groups, or in terms of dyslipidemia like hypernatremia, or in terms of arrhythmia. So the study didn't find a significant difference between the hydration versus non-hydration group. So now this study, so as for their report, non-hydration group was non-inferior or the prophylactic to prophylactic hydration group. In terms of cost effectiveness, they found it is 50% lower cost effective by not keeping them or not hydrating them. So in terms of other adverse effects, they didn't document a difference in terms of outcomes. Now, this study has so many limitations. Out of that, first, it's a single center study. But again, the group defies this contradiction by telling that that's a university hospital in Netherlands. The hospital receives patients across the country, from across the country. So it's a referral setup. They say, though it's a single center, but it caters to various groups of patients. Sample size was smaller. The primary endpoint was the serum creatinine. So the CIN development in terms of the serum creatinine, to whom so many criticize that the isolated creatinine should not be the marker of CIN. Apart from the creatinine, there are so many other markers we need to rely on. But these are the limitations of the study. So what the study concludes, it concludes that, so if you fail to give a prophylactic hydration in some subset of patients, not routinely, in some subset of patients whom we feel the hydration is going to be harmful, in a patient with cardiorespiratory compromise, or maybe patient who is in high risk of developing a pulmonary edema, so it is not inferior to a hydrated strategy patients who developed in terms of developing the contrast-induced nephropathy. Second, it is more cost effective. These are the straightforward answers. This trial it puts its results. Then hydration is again, it's not free of complication. Hydration should not be done routinely. So that's what the conclusion of the studies tells. But I feel the study should be, it's like a the strategy should be individualized. Yeah, that is the conclusion of the trial.